It's Professor Artur Fedorowski from Karolinska Institute here in Sweden. Artur is a professor of cardiology at Karolinska University Hospital as well, and he's one of the country's most distinguished doctors in the field of long COVID and POTS, and also has extensive experience with ME. Välkommen då, kardiologiprofessor Artur Fedorowski från Karolinska. Lång erfarenhet av ME och en av Sveriges mest välmeriterade läkare när det gäller post-covid och POTS, som också är dagens ämne. Varsågod.
Thank you so much for this very kind introduction. It's my pleasure being here, and I really hope that you will enjoy this presentation. And I really hope that you will learn something new from this presentation as well, for yourselves as patients, researchers, scientists, or anyone interested in this issue. I'm not gonna talk about ME, CFS, or long COVID, but I will touch this issue. And the central point of this presentation is something that we call POTS. It has become a household word all over the world due to pandemic. Now, long COVID has brought us a unique opportunity to study this issue. And as Albert Einstein expressed this once in a time, in the midst of every crisis lies great opportunity. This is, of course, a tragedy. Pandemic, long COVID, these are tragedies. But they created a unique opportunity for us to study the subject, but it's not that easy to study. And let's start with this lady, 52-year-old woman, Anna, from Stockholm. Actually, she has a history of deep vein thrombosis, anti-cardiolipin, autoantibodies, IBS, depression, no alcohol, a few different medications. March 2020, viral infection, 10 days, never fully recovered. Let me just go back, because this prompting me just to go on. I don't know what's happening. Never fully recovered. 100% on sick leave, so her life was ruined, actually. Fatigue, shortness of breath, palpitation, chest pain, diarrhea, as you can see here. And after one year, someone is trying to take on it. Some doctors is trying to take on it. 1 year with all these symptoms. It's chasing me all the time. So she was referred to so-called post-COVID service at Karolinska. Now we can move on. And she was investigated at this service. You can see high heart rate, 120. This is not the normal heart rate. This is double as normal. And then you can see here Holter ECG, 102, active standing test, increase in heart rate from 108 to 150. This is what we call POTS and inappropriate sinus tachycardia. So after 2 years, she was diagnosed, finally, with 2 diagnosable conditions. And here we are today, fighting against this pandemic, long COVID pandemic, POTS pandemic, and we are in the long pursuit of understanding. And the fight is not that easy, as you can imagine, as you have seen or heard. Now, you maybe have seen this diagram from one of the recent publications. Estimations here are about 20 million people with post-COVID dysautonomia or POTS and cousins to POTS. 65 million with long COVID. And some of the major manifestations is just POTS as indicated here. Please keep this picture in your mind, and then let's move a little bit on in time. And this is recent publication, almost by the same authors. And now they say about 4 million people affected by long COVID. I think Resia mentioned this number here that comes from this publication. If we calculate 1/3 with dysautonomia with POTS, we'll have 100 million new POTS cases all over the world, with different hypotheses what it could be. Persistent virus in your body, or autoimmunity, or latent virus reactivation. And then we will have all these auto-inflammatory or autoimmune issues, or thrombosis or microthrombosis or microclots in your vessels. So as you can see, there are different hypotheses. I've learned myself one lesson as a scientist and doing research. If there are too many hypotheses, none of them is good, probably. So we have not hit the target yet. This is my personal experience. So even if there are many fancy hypotheses trying to explain what's happening in your body, so maybe we are not there yet. But I'm moving from the micro world to macro world, or from microcosmos to body macrocosmos. What we can see in this body macrocosmos on the larger scale is what we call post-orthostatic tachycardia syndrome and dysautonomia, mentioned in one of the recent publications in New England Journal of Medicine, which is a very respected journal actually. And as you can see here, there's one quotation here that I like very much. Long COVID is not a diagnosis of exclusion. Maybe some of you may not really understand what it means. Do you know what it means? That long COVID is not a diagnosis of exclusion. I will explain it to you. It means that this is not just like there is something very diffuse, confusing, not really defined somewhere there, which we called long COVID. And there are many good diagnoses that you should look for. And then when you have not found anything, there might be some long COVID. We call it long COVID, a sort of garbage. Oh, this must be long COVID. No. This publication points out that long COVID is a diagnosable condition. It should be sought for. It should be diagnosed from the very beginning. So what is POTS actually? What does it mean, POTS and dysautonomia? Let's move on. It's been here around for a while. It has been defined 30 years ago by these two respected fellows, Ron Schondorf and Philip Lowe from Mayo. Women experience an acute onset of persistent lightheadedness and fatigue or gastrointestinal dysmotility due to viral illness. Does the bell ring? Yes. However, POTS may have been around with us for a longer period of time. If you look at this publication from Da Costa, 1871, it was reproduced in this article a little bit later. It affected actually soldiers during the American War, 1860s. So they got some infection, gastrointestinal infection on the war field, and then they were affected by tachycardia. The heart was bumping, bouncing too much. So it was called an irritable heart disease. And actually this is what we see. This is actually the reason why I'm standing here as a cardiologist. It's also something about the heart. The heart is galloping. The heart is beating too fast. And this is POTS. This is very confusing. For cardiologists, it's just like that. There's some lady with some puzzle fragments. It's difficult to put it all together, but what a cardiologist can see is, oh, this is tachycardia, heart rate is increasing on standing, something is wrong, lightheadedness, something doesn't work so well. There's something wrong with this lady. Orthostatic intolerance, you know what it means? Better, worse. Better, worse. This is orthostatic intolerance, briefly defined. No orthostatic hypotension, blood pressure is on the same level. Not really. I will talk about it a little bit later. Duration, at least 3 months. I managed to downsize the duration from 6 months to 3 months. And suddenly, long COVID is the same, 3 months. Quite interesting. Women between 20 and 50 years are overrepresented. Now, to understand what's going on in the body, beyond tachycardia, we composed this MAP score for POTS patients, for POTS symptoms. 5 cardiac symptoms, 7 non-cardiac symptoms. What is very important here, you will see it in a while. If you look at this diagram, there are different symptoms, 12 different symptom groups, but look at this diagram. What you can see is that 5 cardiac symptoms and 7 non-cardiac symptoms, they are equally distributed. So POTS patients have as many cardiac as non-cardiac symptoms. They are equally distributed. Sleep issues, fatigue, brain fog, and palpitation. It's all in the same human package, equally distributed. There are differences in individual differences, but they are there always. Something else on top of POTS. So POTS pure does not exist. There's always POTS plus something. And to make sense out of it, it is very challenging for cardiologists who deal with cardiovascular system only. To make some sense of it, we put it all together, this diagram, to understand for ourselves, for patients and for ourselves, to make it easier for us to understand. As you can see here, these global symptoms and microvascular symptoms are there. They are like brothers and sisters. They are always in the same body. We go back to this diagram. You see headache, brain fog. We move downwards. Chest pain, shortness of breath, venous pooling, swollen legs, and then blue fingers and blue legs in general, swollen legs. So it is all there, and blood pressure as well. Blood pressure is not so, everything is not so all right with blood pressure. I will show you something in a few seconds. This is the typical hill testing. What you can see here is heart rate increased to 130. This is not normal. This is absolutely not normal. But blood pressure oscillations, blood pressure cannot be controlled in a right way. And this is the most important information here. The blood pressure, something wrong with blood pressure. Then we have heart rate measurement, or ECG, actually ECG recording, long-term recording. As you can see here, there are some spikes, increased heart rate on average, and heart rate surge in the morning, and the heart rate does not change over a 24-hour period. It's stiff. So this is not normal. Body should adapt itself to different situation. Then now about blood pressure. Blood pressure is absolutely not normal in POTS. Don't believe in stories like, oh, this is all about tachycardia. Not at all. Many POTS patients experience blood pressure fall during the day. They don't feel well. We call it hypotensive tendency, blood pressure fall tendency. How many? You can see here, let's say 60–70%. This is much more than normal population. In this study just recently accepted, it will be published soon, you see that hypotensive episodes are widespread in POTS patients. And the lower your blood pressure during daytime, the more of this tendency you have. These are these patients that feel very well taking midodrine and fludrocortisone, because we increase blood pressure, we increase vasoconstriction, vessels capacity to contract. Now, we talked about microvascular dysfunction. Hello, there? Focused upon his iPhone. So sorry. You talk about microvascular dysfunction. So this is just the same methodology, just performed in long COVID and POTS patients. This program is chasing me. So, So, as you can see here, this is actually very spectacular. This is eye-opening. More than a half of POTS patients have issues with microvascular reactivity. As you presented before, if you occlude your brachial artery, if you just let the blood go down, so the normal vessel would dilate to get rid of debris of metabolic products. Not in these patients. It does not cooperate so well. So normally is occlusion, and then it should dilate like that. In POTS patients, occlusion, then dilates us a little bit, a little bit, a little bit. If this is due to microclots or any other metabolic processes or inflammatory process, we do not know. But this is not normal. This is objective, this is not normal. We've been chasing this issue for a while. We thought it might be due to dysfunctional autoantibodies directed against G protein coupled receptors that control the cardiovascular system. Adrenergic, muscarinic, they control the cardiovascular system, vasoconstriction, heart rate, and so on. We thought that these antibodies, they just create chaos, havoc in the control of cardiovascular system. And another possibility is neuroinflammation, meaning that there is some inflammation in the autonomic nervous system itself, and maybe both. Okay, so far so good. So we have autoantibodies and inflammation. What's the next step? Let's get rid of it. Autoantibodies, inflammation, inflammatory cells attacking autonomic nervous system. So you should attack this process in some way. So far, so good. Now, this randomized controlled trial with IVIG, with immunoglobulin that you can get through intravenous line, didn't show difference between the groups. There were some 4 good responders, but on average, there was no difference, no major difference in the group. But there were some 4 guys that responded very well to this treatment, but we do not know who. We cannot identify them. Then Paxlovid study that you may have heard about didn't show any difference either. You can see here this dotted line. There was no difference between those who received placebo and those who received Paxlovid, antiviral medicine. For some reason, they reported the same improvement, but there was improvement in both groups. This is another interesting point. So improvement is always there, but there is no difference between the group. One of the most recent studies, we've been supporting this group. They added autoantibody cleaner, efgartigimod. This is autoantibody cleaner. 70% of autoantibodies disappear from circulation. What you can see here is actually that so far so good. The research group was very happy. Patients improved. 53 of them, half of them improved. But then when they deblinded the process, what they found, and we are informed in an interim report, what they found was that there was no difference between the active treatment and placebo treatment. No difference between the groups. But both improved from 65 MAP score to 50. Both groups improved. But it didn't matter whether they received the active substance or not. Quite depressing. But this is what happens. But both groups improved. So what you do with these patients matters. But maybe not efgartigimod. That is the real factor here. So Paxlovid, IVIG, intravenous immunoglobulin, efgartigimod, Maptera was mentioned by you. Both groups improved. However, patients included in these studies, they got better for some reason. And I think this is the extra stuff that makes them feel better. Someone's listening to them, someone's trying to do something, someone's trying to counsel them regarding drugs, increase of water, fluid intake, salt intake, eat in another way, smaller portions, lower body compressions, exercise training, explaining what the disease is from the very beginning. It helps a lot. It absolutely helps. It is the good start point. We cannot get rid of the disease, but we can help from the starting point down to some degree. They were not completely entirely healthy at the end of the study. From 70, 60 to 40, 45, still above the healthy group. Healthy people, they would report 10, 15 maximally. And then we have drugs. Cardiologists love drugs. They can control different things. Heart rate can be controlled down. Ivabradine, people report that brain fog disappears. We have other drugs, beta blockers, verapamil if you have chest pain. You have drugs to increase blood volume. Blood volume is decreased objectively by 10, 15%, up to 20% in POTS patients. Can you imagine that? 20% of your bloody volume is just, it's not there. You don't have it. And that's why it's good to get some intravenous saline. It helps you because you fill the gap. Then we have some special drugs that we have used off-label a little bit. Dexamphetamine for brain fog, it works. Then we have a magic drug for gastral symptoms, for muscle fatigue, pyridostigmine. I've learned myself what it was. From the very beginning, I didn't know how it worked, but now it seems it works very nicely through autonomic nervous system, through increased traffic in the autonomic nervous system. And then we have this antihistamine blocking, mast cell activating, and all these effects. Now, what's happening? Let's say this is not just about what's happening in your head. Don't believe in such claims. These statements are false. This is an objective study, or one case report. Hypotensive susceptibility, high heart rate, treatment with midodrine, compression garments, fluid and salt intake, and then suddenly, whoops, and these patients feel much better. It works, objectively works. Less brain fog, less fatigue, and so on. So we can do quite a lot using our drugs. And you can try out this vagus nerve stimulation, which is another interesting approach. Do you know how it works? Or should I explain it shortly? So you put a stimulator, there are some branches, neural branches here, ending in your ear, tragus, and you stimulate them through some electrical protocol. I will not go into details. And it sends afferent, upward going signals to your brain, to centers that control vagus activity, and then vagus feels a little bit activated, irritated. Oh, I should do something with this. These signals are not normal. This is artificial signal, of course. And then it sends signals downwards. And by the way, anti-inflammatory signals and relaxing, calming the heart. So it works. Heart rate went down. It should work. It should work. Now, let's see. This was very objectively performed study. Randomized, no one knew what they got. And the effect was there after a few months. So it should work. We're trying out this at our clinic right now. So I hope you're not exhausted yet. We're approaching summary. So POTS is debilitating, chronic, difficult to treat condition. We'll not call it POTS in 10 years. We'll probably call it autonomic, cardiovascular autonomic syndrome with different manifestation. Even if your blood pressure doesn't fall so much, even if your heart rate increased by 20, 25, you don't feel okay on standing position. Something is wrong. This is autonomic syndrome, this autonomic dysfunction. You may not hit POTS threshold, but you're not okay. You are somewhere on the scale between POTS and not normal or normal, somewhere in between. Then I don't know, we had these numbers here, 20, 25 million all over the world, maybe 100 million worldwide. Who knows? We cannot count everybody in China, everybody in India. But there's a lot of patients out there, we know for sure. And somewhere, we don't see them because they are not diagnosed. They are diagnosed with anxiety issues, with tachycardia due to deconditioning. They don't train as they are taught or told to. So they are out there. And POTS is not only about tachycardia, high heart rate. We've learned this now. This is about heart rates that increases when you exercise, when you breathe extensively. You have abnormal blood pressure control, up and down, higher during the night, lower during the day. You have this microvascular dysfunction. This is there, this is objectively measured. You have low blood volume, and you have microclots probably everywhere. So pretty depressing as for now. We can do a lot. We cannot get rid of it yet. We'll get there at some point. It affects different organs, not only heart and the cardiovascular system. This is the main, a lot of machinery in your body. This is the main maintenance system. If it is affected, then you don't feel well. But there are other organs affected by the same process. Gastrointestinal system, nervous system from the very beginning. We don't know which is the culprit here. You don't feel well, you cannot exercise, you are deconditioned. All is there in one package. So we can increase the blood volume, not the bloody volume, blood volume. We can use compression garments to increase the cardiac feeling, guided physiotherapy. I don't want to be Hank here. Guided physiotherapy. You know, when you publish this paper and we put this, what was that, pacing or just the physiotherapy. Annie, you can help me. What is this called? Graded exercise therapy. I didn't know what it was. I just put it because it was fancy, just short term. It was a hate storm against us on Twitter. People were just saying, oh, you stupid asshole, you're gonna take life of me. So I didn't understand it. My intentions were good. You should move as much as you can under guidance. This was my idea. But anyway, guided physiotherapy. Ask Annie, contact her, take some advice from her. Drugs regulating heart rate, blood pressure, blood volume, all of this works. But we should just control what's happening in an objective way. You remember this diagram? Before and after therapy, there is a huge difference. This is how we control the effects of the therapy. Antihistamines, for those who are just a little bit, have different symptoms, itching, problem with your gastrointestinal tract, and sudden onset palpitations, they might be helped by muscle activation drugs. And in our opinion, our estimation, this is about 20–30% of patients. Some of you have ME/CFS. In my opinion, like 20% of all POTS patients have this. How many ME/CFS patients have POTS? Probably a half, probably. But everybody has autonomic dysfunction, this is sure. And then vagus nerve stimulation, why not? Buy yourself a device and try this out. It might work, as you could see in the study. Immunotherapy and antiviral therapy have not met our expectations so far. I would not just discard this treatment. As you could see, there were 15 guys in the active treatment arm in IVIG study, iStent study, but 4 of them objectively got really, really better. But why just these 4? This you know, this fabulous, I don't know, we could not identify them. Does it mean 2 minutes left or two questions? Okay, I'm done. Thank you.
Thank you so much, Professor Fedorowski. I'm sure there are some questions for you too, and you can also write the questions, but maybe one or two before we have this lunch break. Judith Bruckfeldt.
Thank you, Artur, for an excellent talk. We collaborate closely, but I would like you to comment on the MAPS score, because that was constructed prior in the pre-pandemic era. And if you could comment on how it works in a post-pandemic era. Is it as good, or are there problems with the MAP score? If you have POTS or not POTS?
I would definitely recommend this score for using in any kind of patients with long COVID issues. It seems to perform very well, as we presented before. So both patients with POTS and without POTS have almost the same symptom spectrum. So it can be used for long COVID, can be used for post-COVID POTS, pre-COVID POTS, inappropriate sinus tachycardia, probably orthostatic hypotension. You can try it in ME/CFS patients. It should perform quite well. I can expect that this score will be modified by adding some items for different conditions. This is my guess for the future.
Is this on now? Yeah.
I think you have to direct it a bit.
Yeah, okay. Thank you for a very nice presentation. It's very interesting. I think it's very interesting to discuss the outcome measures in studies. When you say that they are responders, what measure do you use for this response? This is an interesting discussion, I think, because we have been spending a lot of time thinking about this since we had this negative study. Because some patients, ME patients, have a very variable disease, which fluctuates over years. And if you then start an intervention when you are in one of these waves, then you will probably think that it is the intervention that makes them better. Get me?
Absolutely.
Yeah. So
I got you 100%.
So that's why you have to have not too soft criteria for the response, because then you have this normal fluctuations inside your responders, and that's really important in the placebo group, because we think that was what happened with us in the study. And another thing, some studies, if they when you look at the articles published, then it's very important to actually notice what they define as a responder, because some studies only use a very soft response criteria, like an increase of SF36 physical function on 10 points, for example, which we saw that we saw from the placebo group in the rituximab trial, for example. So all of them were responders in a way. So we had a trial with activity measures, the Fitbit trial, and then we decided after that to have 3 months with no intervention before you start. It's very smart to understand how each patient will fluctuate from the disease. So
thank you for this.
Thank
you for this question.
Yeah, it was not a question, maybe.
Has everybody understood the question? This was a long question.
It was not a question, but yeah. But how?
Oh, this was not a question.
Okay, the question is.
Okay. So.
The question is, what is your reflections during this? I don't know, outcome measure discussion.
So
yeah,
I should.
That was the question.
So the question was, I should give my perspective on the outcome measures in different interventional studies.
Yeah.
In ME and
ME
POTS,
studies,
whatever.
Yeah.
In any study in cardiology.
Yeah. Mm-hmm.
So there should be, first of all, it's good to have a control group. but is exposed to this sham treatment, not real treatment, placebo, whatever. So they follow the same pathway, the traditional pathway, but there is some add-on, and you measure what this additional factor can give you as an advantage, treatment advantage. So 2 groups, control group and active treatment. Then in the end, you should look at how the patients feel and what you can see in objective measures as well. So they should be both there. And of all the studies that I presented, this quite funny study with vagus nerve stimulation, it was done perfectly, because they look at how the patient felt after the treatment, what were the objective measures. There was something for colleagues like Resia. They look at cytokines, they look at different circulating biomolecules. For cardiologists, there was something there, heart rate increase on standing. Then there was something for patients, asking them how they felt in these 2 groups. So you should have these different levels of measurement, let's say micro scale, macro scale, and subjectively how the patients feel. They should be there, these 3 components. Then the study is perfect. And then 2 treatments should be compared to each other with control group, no treatment, and with active treatment. Usually it costs a lot, it takes a lot of time, but this is absolutely the only way to make sure that what we do makes sense, in my opinion, after all these years in the business.
Thank you so much, and I will interrupt you there because the time is flying when the topics are very interesting. And